Thank you for joining tonight's session, Ask the Expert about Bowel Management for Adults with Spina Bifida. These sessions are sponsored by Attendus, Hygiene, WellSpect, and Coloplast, and we're very grateful for their sponsorship and support. Bowel incontinence is one of the most impactful issues that people with spina bifida face and was identified as such in SBA's community-centered research agenda, which I mentioned last week. The questions you submitted when you registered will be discussed this evening, and if time permits, the speakers will respond to the questions that you may submit tonight using the question and answer feature on Zoom. My name is Judy Thibodeau, and I'm a member of SBA staff. I'm joined by my colleagues Juanita Panliner, SBA's National Resource Manager, and Stephanie Myers, SBA's Corporate Giving Manager. I want to mention a few things before we get started. You will be muted throughout the session. You're welcome to submit questions using the Q&A feature on Zoom, as I said. If time allows, again, the speakers will respond to the additional questions. Everyone who registered for this event will receive a link to the recording. Closed captioning is enabled. If you have any technical issues, please send a text to Juanita Panliner, 202-487-3988. This session is being recorded. There will be this is the expert session that we mentioned last week. Now I'm pleased to introduce the speakers for tonight's session. Dr. Mary Ellen Kelly is an assistant professor at Duke University and has been a pediatric nurse practitioner in urology since 2010. Dr. Joy Kerr is a pediatric nurse practitioner who has specialized in pediatric urology for over 20 years and has consistently cared for patients with spina bifida. Over the past 9 years, she has focused her practice on the spina bifida patient population, specifically neurogenic bladder and neurogenic bowel dysfunction. Doctors Kelly and Kerr were members of the Lifespan Bowel Management Protocol Development Team. Courtney Daly is an adult with spina bifida and a mental health therapist who lives in Chicago. Courtney received a master's in counseling psychology in 2018. Courtney brings her lived experience to this discussion. Please join me to welcome Mary Ellen, Joy, and Courtney.
Hi guys, so welcome back, and tonight we are just going to be addressing all of your questions. The first question that we have is neurogenic bowel the same as neurogenic bladder, but in the bowel system instead? Mary Ellen?
Sure. So yes, in many ways it is. So neurogenic is just our fancy word for saying that it arrived or it was founded. It is arising from the nervous system, so somewhere to do with the nerves. So when we say like neurogenic bladder dysfunction, it's saying that there was nerve damage that caused bladder dysfunction. So neurogenic bowel dysfunction, just like the original question stated, means that nerves indeed are what caused your bowel dysfunction. So short answer, yep, they're basically the same thing. And that's why you see them come kind of as one. People with neurogenic bladder have neurogenic bowel. All right, I'll ask the next question to Joy. This one's about bowel accidents. Is it inevitable that accidents occur when you're exercising or walking for long distances?
So that's a really good question. Usually when our patients are walking, that means that there's a lot of extra stress on the abdominal muscles. And so because of the poor anal sphincter tone that many of our patients may have, and many of you may have more accidents based on how well you're doing with a bowel program. If you're cleaning out every night, we need to clear that whole area, that left, remember that D semicolon, the rectum, and we have to clear that area. And if that's clear, you have a better chance of having less accidents. But just using abdominal muscles for walking, running, anything that you're doing can exert pressure on that intra-abdominal and on those organs and cause accidents to happen, unfortunately. So aging. What can we, I'm going to ask Courtney to answer these because I think she's got some really great insights. So, what can we do to manage things better as we age 40 plus?
So I'm 36. I've had a bowel program since around the age, a consistent, well-managed bowel program since the age of 10. I received the MACE procedure when I was 10. As we age, we know that from studies that we have poor motility, we have, everything kind of just ages with the rest of our body, right? We might be slower, we might not exercise as much, things, that just eventually slow down. The things that we can do to better manage it are first and foremost, whatever age that you're at right now, get on a bowel program and that a bowel and bladder program if you're not on one. That is going to help manage things more effectively, and we can kind of hopefully, tweak things as you age. We're luckily in an age that, in a time that there are more options than there ever have been. So, I think the message here is to definitely just do things the sooner the better. And hopefully you can find an adult care provider that will help you, manage the changes that could come. And then we have.
That second part of the question, does incontinence progress with age? Or if you have it somewhat managed by age 40, can you expect to maintain that level?
So yeah, incontinence, we don't really know if it progresses with age. We do know that it changes. We do know that there are changes within, everybody's body as we age. Specifically for women, we know that perimenopause can cause issues within doing a bowel program, and things change within the body. Hormone levels change. So that could also indicate, there could be some more accidents, there could be constipation. It depends on the person. That's the thing that makes this the trickiest part. Every single case is going to be different. Can you expect to maintain some level of function? Like I stated before, absolutely you can if you have a good bowel program in place. And so that's the message that we're just really trying to drive home. Do you guys have anything to add?
I think you did great.
No, great.
Okay, so this question is, my adult daughter had a bladder augmentation in youth. She had many small bowel obstructions in recent years. 2 surgeries found a connection to the previous augmentation. How common are small bowel obstructions with spina bifida or from an augment?
This is a great question. And I actually had spina bifida clinic today and happened to be around a whole lot of surgeons. So I took the liberty of making sure and polling my surgical audience to make sure that the information we were going to tell you was correct. As I don't actually perform these surgeries myself, just help to manage them on either side. So anybody who has any major abdominal surgery, and bladder augmentation definitely would count as a major abdominal surgery, is going to be at risk for what we call adhesions. Adhesions in the abdomen are what can put you at a higher risk for a bowel obstruction down the road. So it is the presence of these adhesions secondary to just having abdominal surgery. It's not actually related to the fact that it was a bladder augment. Traditionally, bladder augments over the last, 20, 30, maybe even 40 years now are made with the colon. There are some that used to use the stomach, but kind of modern day augments use part of the bowel. But even though it does use a part of the bowel, that should not be the reason that you would have a small bowel obstruction. So it has more to do with the fact that you just had major abdominal surgery that can cause adhesions. Adhesions could cause bowel obstruction. Regarding kind of how common is this? To be honest, we don't really know. It's really difficult to kind of quantify that. It's not something that we specifically are always picking up. As we are learning, a lot of adults with spina bifida sort of don't continue to follow with adult spina bifida clinics, as there aren't as many of those as there are pediatric centers. So a lot of that information just might be lost in the regular data. So I'm not sure about that exact correlation. Also, there tends to be a lot of other abdominal surgeries that everybody gets. So that makes that data really difficult to tease out. Okay, this is on stool consistency. I'll ask this question two parts to Joy. So, Joy, what is the best way to help to control watery stool?
Well, watery stool can be caused by a number of things. So some patients with spina bifida actually don't have slow motility; they have motility. So that means it's really moving through so fast that the water is just not getting absorbed, and then you have diarrhea. Um, but some people have a very slow moving bowel. It causes constipation, and that poop is kind of moving through so slowly that too much water is absorbed. And then it becomes hard. It sits in the rectum and it becomes a big block, and it blocks the poop from kind of getting out. So what's behind it, the softer poop, is able to push its way around and leak around that hard stool. So those are two reasons for, just irregular diagnoses. You could have an infection of the colon, like C. diff, and that would be really something that we'd find in a patient who may have been on a lot of antibiotics for some reason. Some of my patients tell me that if they eat certain foods, they are guaranteed to have diarrhea. And some people use that as a means of their bowel management as well, because it's an easy way to get cleaned out. So foods that are high in fat, like fried foods, and then just being on an antibiotic for treatment of maybe even a UTI, depending on which antibiotic they need to give you, can really cause some really GI upset and make things really miserable. So there are a lot of reasons why, but I would say if you're continuously having watery stool, I really think it's important to get in to see a GI or somebody. You might need a basic set of testing, like a stool culture set, and maybe even an X-ray or some other kind of GI study, just to see what's really going on.
And somebody did just happen to add to the chat that sugar-free candy sometimes contribute.
Oh,
I'd say in gummy bears.
Yep.
mhm,
Gummy
mhm.
bears are a interesting way to do a clean out.
And I think the answer to the second part of the question is the same. It's, if you're having diarrhea all the time, it's very similar. It could be due to overflow from constipation, your diet, or any kind of medication issue.
Hold on, let me just
Go ahead.
second. So sometimes, we get a lot of questions. I help moderate the social media of the bowel management programs on social media. And a lot of times there's a very big misconception that diarrhea means that I'm not constipated. And that is just, it's such a myth. And I just want to make sure that everybody knows there's so many different things that can attribute to diarrhea, but one of them absolutely can be constipation. And that is something to look out for.
The
Thanks,
example
Courtney.
that we use, or I use in clinic to explain that often, I used to live out in California. There's terrible traffic out there, but there's terrible traffic, it seems like everywhere now. But it was very easy to say, think about a highway full of cars, right? So your colon is a highway full of hard poop, the cars, but the motorcycles still get through. They just right on through and make it right through the traffic. So that could be the loose watery stool just is flowing right through those rocks of poop. So you can still be constipated, but have diarrhea or loose stool.
It's a great analogy. Thanks.
It really is. I'm going to steal that.
I'll
It's
get
a good one. Everybody can relate. All right. Oh, sorry. Let me move us.
All right. So I'm going to ask Courtney, how do I deal with constipation?
So again, I sound like a broken record at this point, but prevention is key. The thing, okay, so the number one thing on here is, good diet, right? But everybody always says, and this makes me laugh because I am a child of the late 80s, early 90s. We were always told when I was very, very little to just increase your fiber. Just keep having fiber. It'll be great for you. And we learned that that is not the case 9 times out of 10 with neurogenic bowel. And so if we're talking about fiber, we want to talk about food. We want to talk about the natural way to get fiber, and that is through your food. Also with that, you don't want to eat a giant bowl of broccoli. You want to increase these things slowly. You want to incorporate them into a healthy diet. Also, key, and this goes for literally every single human being. This is not just spina bifida related. We all need to be hydrated. Nobody's hydrated. So we all need to be drinking our water. We all need to be having good hydration. That helps with having a successful bowel program. And again, key is a bowel program. When we are constipated, because we're humans, it happens. People eat things, whatever the reason, people get constipated. You want to consider a very unpleasant thing, but you want to consider to have a bowel clean out. And we already have those things for you guys. We have that written down. We have the recommendations. Those will all be posted later. But if you already do have a bowel program, consider doing a clean out and doing a reset, so to speak, right? Because it kind of just does exactly what it sounds like. It resets you. You kind of start from zero. And that way you kind of have a better idea. Is this just food related, or is there maybe something else going on that I haven't figured out? Okay, so if we're going to talk about transanal irrigations, and the question is, if you use the irrigation system, how do you know that you are finished and not going to have an accident?
Yes. Crystal ball would be the best way. So this is not going to be tried and true. It doesn't always work perfectly, but generally we find the most times someone will have, we call them aftershocks. Like you have all the regular bowel movements, clean up, you're good, you're going on with the rest of your evening or your day, and then boom, you have another one. Generally, if it's that type of accident, it's usually because of one of two things. One, you actually ended up using too much liquid. So your body ended up kind of storing more liquid, especially if you have like a redundant colon. You might just have like pockets of water still
Can you
in there.
explain what a redundant colon is? Maybe
Oh, sure.
we don't know. Maybe we don't know.
You got kind of a stretched out colon. It's think of it like having a sweater, and then you overstretch it and it won't come back. Colons come back somewhat, but it's kind of in that same idea. You take that arm of that sweater and you've stretched it. It's longer than it was when you started. So chronic constipation, which we define as having constipation for greater than 3 months. So some of you may have had it much, much, much longer than that. But chronic constipation can cause redundancy because it stretches out the colon, and you can actually end up with extra like loops and twists and turns in the colon. So you may have just a different shape to your colon. You may just be using too much water, and essentially eventually later more water or water mixed with stool will come out. So it's important to use the right amount and not always just increase, because you can get to a point where there's just so much water, you're more likely to have an aftershock. Additionally, not so much maybe with TAI products, because you shouldn't be adding, for the most part, any additional things beyond water. But if you're using like a MACE or a CHATE or sacostomy of some type, and you're using a stimulant, whether that's glycerin, soaps, shampoos, etc., those are all kind of stimulants, or even like a flea enema, that if you have too much stimulant, it's going to cause too many contractions in your colon, and you might continue to have some contractions, which is going to expel some stool.
With
Joy?
Well, there was a question here too. Do you recommend the Parastine system? My daughter is 17 and trying to become independent.
It's totally going to hit on that. I saw it. Thank you.
Sorry.
Okay, so I think transanal irrigation, personally, I think it's a great option for many individuals. Navina and Parastine, as we kind of talked about last week, are the two most common products in the US. It's the same mechanism of action for both of them. You have a balloon catheter that you place in the rectum. that balloon inflating is taking the place of a malfunctioning rectal sphincter. So it kind of blocks the exit. And then you can instill water above that into the colon. And as it does that, it's going to kind of fill and create some pressure there. And it's going to help to start some peristalsis, maybe even give you a little bit of an anal rectal reflex, which is like a normal way to poop. So it might help to exhibit a little bit of that. It's going to help to get the colon and the rectum moving the poop through. So as soon as all that water is in, you can deflate that balloon. The balloon comes out, and ideally you have a bowel movement behind it. Transanal irrigation is not available everywhere because it's not currently covered by Medicare. We're hopeful that'll change in time. There's an active fight for that. So it's not available to everybody. But if it is something you can get, it is a really nice option for individuals. But it's just something to try. A lot of people can do it independently. Some still cannot. But I think it's a great thing to try out if you've kind of tried other things like cone enemas and such, and you want to try to be more independent with your bowel program.
So one thing to add to that, people that have this is all anecdotal, but people that have used these devices have stated if they've, previously used like a cone, let's say, they have only, they went from a cone to a Peristeen or a Navina, right? The evidence is basically showing that water isn't sufficient enough. So there are people that are using additives with the Navina and Peristeen and having much better results because their bodies are used to that. So if you're using one of these systems right now and only using water, don't get discouraged. Try different things, try different additives. That's also an option.
That is totally off-label use, so I will not conduct that.
Yes.
I will not say anything about that.
I know, wink, wink. I can't. Hey, I'm trying.
Mary Ellen, I just want to ask you about people who use medications that can also be stimulants.
Mm.
Sorry, I was writing a note to myself. That's something else I wanted to say. Did you have something you wanted to add? And
No, I just wanted to, you had said a caution on stimulants. So you're talking about stimulants that are added to the mix, but
You're
how
not
about,
talking orally.
I'm sorry?
You're not talking about oral. You're talking about in the enema
Oh,
itself.
well, so she was just saying if you're adding things like glycerin or soaps, but how about people who take Senna or people who take other oral medications that could act as a stimulant?
Yep. I would say that's a really common reason that I see people in clinic who continue to have incontinence after a good irrigation or bowel program. I've seen quite a few adults who come in on these really big concoctions that they're on. And we actually just start pulling things out of it, generally some of the stimulants, and they start seeing a lot of results. So you do have to play with it a bit. I want to go back to the original question just for a moment because I had a little epiphany. If you're first learning this and you're trying to figure out how long do I need to sit, what I tell patients to do is just to get a piece of paper and write maybe 10-minute or 15-minute increments on it across. And just kind of, as soon as they're done instilling the water, they have turned off, the balloon is now out, and we're now kind of in the pooping phase, to just keep track of time. And every time you have either poop or water hit the toilet, I say put a check mark in that 15-minute box. And when 15 minutes is done, now we're looking at that next 15-minute increment, right? So 30 minutes from when you finished. And if you have a bowel movement there, click it. You could use smaller time increments too, 5 minutes, whatever, and do that for a week or so. And you'll start to see when your body sort of generally is done. Maybe it's 20 minutes later, maybe it's 30 minutes later. And you're like, oh, look at that. I actually don't tend to have accidents after that time point. It can just be a nice way of kind of tracking and keeping a visual for yourself. All right. Does anybody want to add anything else to this question? It seems like that was a good discussion.
Nope.
Cool. Okay. So I will ask the next question, still kind of in this topic. Joy, this one is talking about young people or young guys in their transition clinic, and they tend to want to try to manage their bowels independently. I would say this is guys and girls. Everybody would like to do things independently. How do they do that functionally with Peristeen? Is that possible or any tricks? And does there tend to be pain or discomfort with that?
I think that's a great question. So I just actually trained a young man yesterday with Peristeen who had been doing a cone enema pretty independently. He's 15 years old. And he was very private, but so the tricks that I typically have is I think it's really challenging to try to reach behind you, and you have to have a place to lean, a place to put your feet so you can stabilize yourself. So all those things are really critical. So one of the things that we do in our clinic is that if you're struggling to do your bowel program, we may have you have an evaluation with an occupational therapist who will walk through every step of what you need to do and try to figure out a better way to do it for you and whatever, your abilities are. So that's number one. Number two, that's not always an option in the real world. And we know that. So one thing that really works well is, first of all, if you have a transanal irrigation, Peristeen and Navina, they both come with straps. So you can actually strap the pump device to your leg, which frees up both hands, which is really nice. And Navina has a automated pump as well. You still need to push some buttons, but you don't have to even manually pump it. But Peristeen does not have that, but Navina does. So number one, to try to get the catheter in for guys in particular, I have found that a lot of them have to go from the front. They just spread their legs and they go in from the front, and they go between their legs, and they can get it in easier and lean on their elbows on their knees, which is really nice. I'm trying to see if I can, they're kind of leaning forward and they have the elbow, maybe I can get my arm down, their elbow on their knee, and then they're putting it all the way down and through so that they have that ability to stabilize themselves better. And that works really well for a lot of my patients. So that's been a trick, and girls can do it that way too. I've had girls train that way as well. I think the hardest thing is to try. We always think you have to do it from behind, but you don't. You just have to know what the right place is to put it. Number one, for girls especially. And you have to be able to have that ability to balance yourself well while you're sitting on the toilet, and stabilize everything. And then having it strapped to your leg so you can pump with one hand and hold with the other is really helpful. And then the other question says, is there pain during the process or discomfort? And I wanted to address this because I have a number of younger kids who have gone from a cone enema where it just wasn't working well for them. But as soon as you put them onto a transanal irrigation and you blow up that balloon or inflate that balloon, they have a lot of discomfort. And so it's not everybody. It's a very low number of my patients that have this. And if there is any discomfort, normally like with this guy I taught yesterday, he had 500 cc's in like a minute. And I'm like, are you okay? Do you feel comfortable? The whole time I'm checking him. Are you okay? He's like, I'm fine. I'm great. And he was done in 20 minutes. He sat for 20 minutes and he was done. And he was like, this worked great. Thank you very much. So, but if you're having any pain during the process of putting the fluid in, you can always pause. You can just take a break from allowing that, just don't increase the fluid because that might be causing some discomfort. See if and pain may be also that your bowel is kind of trying to peristalsis and push things out. That might be also what you're feeling. But I think the one pain that I consistently hear about is the pain in the bum. When that balloon's inflated, it just may be that Peristeen or balloon catheter is not for you. And there are other options. So we have things like CHATEs, and we have, the cecostomies and the MACEs. So don't feel like you don't have any place else to go. But this is really a good option. So I'm going to ask Courtney about antegrade colonic enemas. So does the ACE procedure need to be checked? It was done 20 years ago, and we have to use a smaller catheter to get it in.
So, generally speaking, again, this is a, pediatric to adult care transition issue that we run into, as we well know. So generally speaking, if you had the procedure done by a pediatric surgeon, you can, if you think that there might be something going on or anything of that nature, you can check in to see if you can still be seen by them. If you can't be, as long as you can pass the catheter and do your irrigation, there shouldn't be an issue. So sometimes what happens is it's called stenosis of the channel. And what happens is that channel can get smaller. And so something that you can do is you can try to pass a little bit of a larger catheter through gently. Do not shove it on in there. And leave it in the site to potentially dilate and increase the size of the channel. There's also things called MACE stoppers, and you can also create what's called an L stent. And this is just a tied catheter that you could knot into your stoma and help keep the channel open. If it's ever difficult to pass the catheter, please stop. Don't do it. Don't push things through. Stop. We need to stop right away. And then again, you might be able to see your pediatric surgeon because you were established there at one point if you're an adult. If not, again, hopefully we have resources for you that are going to be available that you can hook up with an adult surgeon to see if there, might be an issue. Okay, so let's see. We are going to talk about the MACE, a Malone antegrade colonic enema. My daughter administers the enemas every other day through her MACE. She stays relatively clean. However, each enema takes at least 90 minutes to complete, if not more. Is this a normal amount of time?
Normal is going to be, I think, dependent on each individual. I think that we've kind of gotten complacent, and I think a lot of us, even from a clinician standpoint, are like, oh, 90 minutes, that's not so bad. I think it's pretty bad. I think most people on the call would agree with me. It shouldn't take that long to do a bowel program, but we try clinically to get people down. I like the 45-minute or under mark. That's kind of a personal goal that we aim for, but that's not always realistic. There's a lot of factors on that. So that timing of how fast something is going to work for you is going to depend on a few things. It's going to depend on your personal body's ability to peristalse. So again, we talked about that last week. It's that movement in the colon, the actual contraction of your colon to push the poop along. So it's going to depend on that. It's going to depend on what you're instilling. So are you doing just straight liquid like a water and saline? Or are you also adding a stimulant? So again, something like a glycerin, soap, shampoo, something that's going to cause some stimulation, some extra peristalsis and irritation to the colon. And how much liquid you're using also. So if you are putting in large volumes of fluid, say over 500 mLs of fluid, that's going to take longer, right? All of that needs to travel now from in a antegrade continence enema or sarcostomy, chate, those kind of things we're talking about. That's entering your body on the right-hand side, and it has to travel up, over, and then down. So it's going quite a ways, and if you have a lot of volume, that's just going to take longer to kind of get there. As we have there, we typically expect 30 to 60 minutes. I think that's sort of where we reasonably say, okay, this could improve, but it's okay from a start to finish. If it's taking, again, that 90 minutes, 2-hour mark, etc., I think it's worth reaching out to somebody and seeing what kind of tweaks would work for you to try to cut down that time.
Mary Ellen, do you think that if somebody was taking that long, if they did maybe 3 nights in a row, would do their irrigation, would that kind of reset them back and maybe have less time?
It might. And I think Courtney touched on that as kind of like a reset is if you have a decent program, but for some reason you're suddenly seeing things are taking longer, you could just do your program 3 nights in a row or 3 times in, every 12 hours, 3 times if you usually do it daily, but kind of increase that frequency slightly to try to push any hard stool or extra stool that's not normally there out of the way to try to get back into a routine.
So something that caught my eye with this question is the person said that they do it every other day.
Right.
Now, I'm also a person who does it every other day due to various reasons. I have a full-time job. I have things that, it fits for my lifestyle and it fits for my life. So if you are doing it every day, there is the caveat that you're going to have more stool and that you're going to probably increase that time a little bit. So you have to also weigh your options. Do you want to do it every day? Is it still going to take that 90 minutes? Or do you want to keep it every other day and, have that one day free where you don't have to do anything? It's so important for everybody to figure out something that works for them, right? And that's the thing that we're looking for. If for me, it was even when I was doing it every day, and that again, this is just my experience. When I was doing it every day, I'm one of those unfortunate people that it did take me 90 minutes every day, no matter what we did to tweak it. So I chose for my whole, betterment of my mental health, my physical health, everything, that your life, I chose to do it every other day. So you kind of just have to play with it and see what's worth it.
Yeah. Yeah. Taking into consideration your goals in your life is definitely the number one thing.
Yeah.
Oh, this was a picture we just wanted to put in here because I know last week when we talked about it, we really just had a photo that I think showed a Chate tube. So here's some other examples when we talk about a cecostomy or a MACE. Remember, the MACE was using your own appendix to create that catheterizable channel, but a cecostomy is using something else. So something man-made, store-bought, let's say. So like a Chate tube is here. That was that little plastic white square that had the like curly Q on the inside. Here they have a different tube. It looks like maybe it's like a mini ACE button or something else. So another little physical object that is making that connection between your abdominal wall and the inside of your colon. And then you're doing your irrigation via a catheter or connecting device through that channel into the colon. And again, as we mentioned, I don't know if you can see my arrow, but if you're doing anything from this right side, especially again, that large volume, you're having to get it all the way up, all the way over, all the way down, around, and then out. So it's a long way to go.
And that colon can get really squiggly and be up and down and all over. And you have what we call a dependent loop. And if fluid gets into a big loop that's hanging down, it may not come through for a while. So that's one of the big problems that we have with large volumes.
This is why we're stressing, and I know this is focused to adults, but you guys probably are the ones talking to a lot of the youth with spina bifida as well. And it's why we are saying like we've got to start these programs younger and younger to try to help reduce that redundancy, those loops, all that constipation that you start as a child, right? And it just gets worse. And I think if we can keep somebody from getting constipated long term, the kids might have more success as adults. So it's all of our job. All right, Joy, this one's going to you. What can we take to help maintain better bowel habits? And how can I generally get started with a program if I don't have one?
Well, I would say for maintaining better bowel habits, it's really, we talked about already diet. We talked about fluids. I think the one thing we didn't talk about was exercise. I think that is really key. Even for some of our patients who are in wheelchairs that have the ability to do some type of exercise, that makes a huge difference in getting things to move through the whole system. So that's really important. So what can you take? It's a really good question. I think my first choice would be always good nutrition, fruits, vegetables, whole grains, and fluids. There are some nice supplements out there. We have some things in our, some people will take some magnesium orally. Some people will take senna, and senna is something that can help, but it is a stimulant. And so we want to make sure that whatever you're taking, that somebody is helping you manage that, and that you're not just, I'm going to try this and I'm going to try that, and it could be a complete disaster. And so I feel like everything that I prescribe is really based on my patients' habits, their diaries that they keep. That's really important. When patients are having soiling, I really ask for at least a minimum of a 3-day diary. Give me 3 days worth of information. What are you doing? When are these happening? We'll make one little adjustment at a time. We don't make big adjustments. And then we just keep working with them. So I don't like to say that there's any one thing you can take to make it, to maintain a better bowel habit. Better bowel habits. It's a lot to get out. But I think exercise is really key. And I would really advise that people get involved in exercise, because I think that really helps. And then how to start a bowel program in your 40s. Number one, I think it's going to be really important to get connected with an adult spina bifida program, because they will have the experts in helping you figure out what it is that will work best for you. Number two, Colleen Payne, I saw her sign on, would always say, you got to start with a clean out. And for a lot of my patients, I think I talked about this last week, I can't just do oral medication clean out. You need an enema from below, and you need you need also a lot of Miralax from above in order, and some Senna or Dulcolax or whatever it is that you choose, but your provider chooses. But the cleanouts are really important to get. If we can start with really next to nothing in there, anything that you do is going to be much more successful. And so that's how I would start.
That's great. Courtney, do you have anything you want to add? Anybody?
No, I think that, again, it's going to be finding somebody that can help you, do all of these things. The one thing I do recommend, if you're gonna, get on some sort of routine, do it for about a month. Don't just do it for a week, and if it doesn't work, you quit. You gotta be consistent. Yeah, you do. You have to be consistent, because that doesn't give us the data that we need to then make a, informed decision. A week of a bowel program, 9 times out of 10, it is not going to be what it's going to be forever. So you have to do it for a good amount of time to figure out if it's going to be the thing that works for you.
Courtney, I have to tell you, I want to share this, because I had a patient who they were doing a cone enema on the bathroom floor. He's 16. They were doing it on the bathroom floor, and then getting him onto the toilet. And then it was taking an hour. They had one bathroom, and people were coming in and out of the bathroom while he's on the floor getting his enema. I mean, it was just like, they were just like, this is part of life. Well, I taught him how to do Peristeen. He did not want to do it. He said, I'm not doing this. I'm not doing this. He told his mom. And I said, would you just give it 1 month? Would you give it 1 month? They did a video visit a month later, and he goes, I was wrong. And I said, you were? And he goes, I feel lighter. He lost weight. He was like, I feel like a new person. I didn't realize what it could feel like to feel empty.
To literally feel like you have poop in you. Yeah.
Yeah. I mean, he had a lot of poop in him that he was not getting out all the time. So it's good. All right. So diet and nutrition. This is for Courtney. What foods are great and inexpensive, or what foods should I avoid to eat on a daily basis?
So I always go back to the basics. When we're babies, we do the pee foods to help us poop, right? So that literally translates into adulthood. Peaches are a great option, pears, plums, prunes, raisins, not a particular fan, but people are. Peas, broccoli, cauliflower. Uh, Now, I want to talk about chia seeds and flax seeds. So, this is a big, big caveat because these can, in neurogenic bowel, this may or may not be a true story. Um, they definitely can cause you to be backed up. If you eat too many and you do it in a way that you are not properly hydrated, you don't move enough. And so be careful with your seeds. Be careful with your chia seeds and your flax seeds. That's all I'm just going to put a general warning out there. But again, we go back to the hydration. It's, we got to get our water in with fiber. That's the key. So any other
Anything to avoid?
Um, so yes, of course, all of the, we simple carbohydrates like your white flour, your breads, your pastas, your unfortunately though, because those are delicious, but everything in moderation, right? You can still eat these things. Cheese. I am a huge lover of cheese, but I don't care if you have a neurogenic bowel or a quote unquote regular working bowel, cheese is going to bind you up. So, you got, again, it's following those basic nutrition needs that you find in schools, and you guys, we all get educated on them. Whether you have neurogenic bowel or not, those are the things that we all should probably be looking at.
All right, I'm going to move us on so we can try to get to all our questions here.
Okay. So I get a sharp pain on the right side when it's time to take a bowel movement. What does that mean and what should I do? Mary Ellen.
Sure. Get that looked at. That's the short answer. If you're having really significant sharp pain, that's something that you do want to have somebody look at, especially if that's an acute thing, especially if you see blood, if there's anything else going on, if you start feeling dizzy, that's something that can sometimes happen for different reasons. But those are concerning things that we want to make sure you're getting looked at. It might be nothing. Sometimes pain can just be gas. It could be peristalsis, again, the movement of the colon, those contractions, especially if there's hard stool, that can be uncomfortable or just kind of increase that pressure. And as we mentioned here, if it's kind of predictable and it's coming right before you poop, see if it's just kind of like a timing situation. But again, if it's really a sharp pain, something like that, something that's changed, please don't take our advice on all that. Go get it looked at.
Also, I think too, I have I have a few adults still in our clinic who they have problems like, oh my word, I just lost it. The outbouching of the bowel, diverticulosis and diverticulitis, and those types of things, I'm sorry, can occur, and they can be pain, and that can be painful too. So if it's continuous, you should really get it checked out.
Oh, Nope, sorry. All right, so Joy, since you were speaking, we'll let you keep going. Somebody was asking about if, just like you were saying, diverticulosis, I'm going to say IBS. Can you have some of these other GI symptoms or syndromes with spina bifida?
Yes, as we become adults, you can get anything that anybody can get, and so it is possible. And if you think that you have IBS, you should see a GI specialist who can diagnose and treat it. And you can still get all other adult concerns or diagnoses like the diverticulosis and the diverticulitis. And some people are diagnosed with Crohn's or other different things. But you can get really good help with a good GI doctor. And if you're connected with a spina bifida clinic, they could probably point you to the right person.
I think the thing to reiterate here is we get really, as a person who has this, we get really caught up with just only treating the spina bifida aspect of our lives. And I think it's really, really important to understand and realize that we have all other things that can happen to a human body. And it is unfortunate, but yes, we can have other things that quote unquote able-bodied and normal bodies, right, have. And so I think it's really important to remember that, because sometimes we do just get caught up in the, oh, it has to only be spina bifida related. Unfortunately not.
It's so true.
Thanks. All right. So pain. So many people with spina bifida have tethered cord syndrome. Also, many are aging and have pain, so they have a pain management opioids, which can turn into opioid-induced constipation. How do these issues affect bowel function in people with spina bifida? Courtney?
So I actually have a unique perspective on this, given my adult status with spina bifida, but I also am a mental health professional who has a license in addiction therapy as well. So I know I know what narcotics and opioids can do to a body, and it might be something that you need to talk to your pain management clinic with if you do have one. And depending on who is providing you with the opioids, we have to have the conversation of, I have a neurogenic bowel, and it is really important that I continue to have regular bowel movements just like everybody else, but it could be harder for me because I have constipation. We want to be able to, this is all about quality of life, right? At the end of the day, this is about quality of life. If you have to be on some sort of pain management, we don't want to take that away from you, but we also want to make sure that every other system isn't being affected. So this is a conversation that you have to have with whoever is prescribing you the opioids, any type of narcotic in general. Or if you're working with a pain clinic, talk to your pain clinic. They're a wonderful resource, and they can give you alternatives to just not opioids. It's a conversation that you should be able to have with your care team. Anything else, guys?
Yep.
Okay. Is it normal to not be able to tell the fullness of my colon?
Yep. That was our short answer. Very normal in somebody with spina bifida, right? We have decreased sensation. And so that's going to be sensation everywhere. So, as we talked last week, in kind of typical bowel function, you would feel that pressure and at the rectal sphincter that would say, hey, I need to go to the bathroom. I need to find a toilet. It's very normal to not have that when you have spina bifida. So totally normal. And you might have to kind of judge based on other symptoms, increased gas, you might feel rumbling, you may notice some like just belly distension, kind of like bloating. That might be a sign, or you might not have any signs, but that is normal. Okay, we have a couple we'll try to get in here if we can. So, Joy, this person writes that they lost the feeling for having a bowel movement, and 99% of the time they're using a manual discharge.
Yeah. So thank you. Thank you. Patients with neurogenic bowel really do have that decreased sensation, like Mary Ellen was talking about. They don't always get a sensation that their bowel's full. That poor transit time can lead to constipation. So some people do use digital stimulation or digital disimpaction, where they use their finger to remove stool. And if that's working for you, I think you can continue to use that method. But I really highly recommend, if this is something that you feel frustrated by, if you're having soiling, that you would seek the assistance of a spina bifida clinic provider who can really help you get cleaned out and start a really good program, because I think it could make a big difference for you.
Yep. And generally, this kind of evacuation will work better if somebody has a higher level lesion than somebody with a lower level lesion.
This is a question for Courtney. I cannot find a provider to help me manage my bowel routine. I've heard that urologists can help. Can I ask my urologist to help with my bowel management? Or if I need to make an appointment with a new urologist, can I ask them about my bowel management? And can they prescribe management equipment such as, I'm going to say TAI, transanal irrigation? So Courtney, tell us what you think.
Yes. So your urology department is going to be your holy grail for the bowel management side of things. If you don't have a provider right now, again, we're going to provide you guys with a list of places that have adult clinics or pediatric clinics. We can always give you guys those resources as well. Urology is going to be your main go-to for bowel and bladder. If you're finding that, maybe you haven't had the bowel management conversation with urology, absolutely bring it up. It's your body, it's your time. They're there to help to, support you. So, what I recommend is if you don't have a current bowel program is to make a list of concerns that you do have before the appointment to, everybody gets a little nervous before we go into an appointment, right? So it's better to be prepared. Get all of your questions written down, put them in your phone, write a list, and be able to ask these questions when you do see your provider. But yeah, urology is going to be your main source for all of those questions and concerns. Okay, the future. What do you think bowel programs of the future are going to look like, guys?
Well, it's kind of a conversation for everybody. It's nice to dream. Hopefully someone will come up with something great. I'm hoping we'll have things that are faster. I think people are doing work at trying to, restore nerve function. People are doing work looking at medications. There's more about like anal plugs and sphincters. I think there's a lot out there. I don't know what's going to work.
It's trial and error, unfortunately.
Yeah,
Every
but there's a
patient
lot more
is so
research out there.
individual, right? I mean, no two patients have the same bowel program.
Absolutely not. You're not going to find it. That's what makes this particular area of spina bifida so frustrating, but very, very interesting for people who would like to help us because we have a lot of different things that we bring to the table. So,
All you engineers out there, innovators, keep going, keep thinking, come up with
yeah,
something great.
can we get it together? Literally. Yeah.
Importantly on here is this QR code. This goes, I believe, directly to the Spina Bifida Association's website. You could also just go to the SBA's website and underneath, I believe it's their research tab, you'll see the lifespan bowel management protocol that we've talked about a few times. In the appendix there is a copy of the bowel diary. There's also information on clean outs. There's all sorts of stuff there. It's also a really, really great resource. We wrote it purposefully for individuals to be able to basically say, hey, new provider that maybe isn't very well versed in treating neurogenic bowel, here's something that might guide you. So it's made to be a guide for clinicians to use to help to treat somebody with neurogenic bowel, especially providers who are maybe not super comfortable with that, don't have a lot of experience with that, just kind of aren't up to the latest. So it's a resource that you can give to people as well. So please do feel free to do that. And I do want to pull up here and see if I can pull this off real quick. We do also have a list of the adult clinics. Here we go. These are the current list of adult spina bifida clinics across the country. I'll just kind of slowly scroll this as we kind of conclude up. But Alabama, Arizona, California, Illinois, Indiana, Maryland, Florida. So there are some in various states. I'll move to the next. Is this page available on the SBA website?
It is not yet, but I will upload it. And also, if you give me a nanosecond or two, I am going to put it in the chat so you guys can
Perfect.
download it. But
Oh, even better.
moving slowly here, but just give it a moment.
And while you do that, Juanita, I want to thank Mary Ellen and Courtney and Joy for tonight and for last week. And I think there are questions that have not been answered. And please, we have them, Juanita, right? So we can seek some answers for them.
Honestly, I think we've gotten to all of them.
Yeah,
Have they
they
answered?
they just yeah, I think they pretty much got through all of them.
And
If
I've
there's
been
anything
typing as
that's
well.
yeah, no, you've been awesome about responding in the chat and Q&A, but if there aren't any, I mean, we'll take a look, but if there are any, then we'll make sure that we send them out.
Lauren
Responses.
said there's
Right.
one. I'm trying to scroll up to find it, Lauren.
While you scroll, I will thank Attendus, WellSpect, and Coloplast again for supporting this session and last week's session. And y'all keep working on this. This is a big deal for everybody at bowel management, and we support research in it. We look for your ideas about bowel management. Providers who've been helpful to you, if you let us know, we can share their names with others. Just something that we are very interested in, care a lot about. Did you find the question, Mary Ellen?
So there's a few people saying they actually put it in the true Q&A, not the chat, but my Q&A box is empty. So I'm not sure if, Juanita, do you see something
Oh,
different?
I do see the Q&A. So there's actually a few, so it depends. I don't know how much time we have, but let's see here. We have okay, so there's one about I notice when I don't take Lomotil, I have what I call bowel spasms, like sudden feelings of movement down there. Do you know what that is? Is it the intestines or colon? It happens several times because I can get all the stool out at once. I go several times within a few hours. Oh, because I can't get all the stool out at once.
We typically don't prescribe Lomotil very often. There are a few patients, again, who have that hypermotility who actually do need it. But Mary Ellen, do you have very many patients who are on Lomotil that you
I
prescribe?
can count them.
Yeah. I mean,
Out of
honestly,
800, I know of 3.
Lomotil is only causing most patients to be constipated, and what the diarrhea that they think they're having is probably soiling that's coming around that. Courtney, any thoughts on that?
I actually don't because I'm not familiar with Lomotil. So
Yeah, we'll use it when we have those occasional people with like a hypermobility, not mobile, sorry, hypermotility, just to kind of slow the movement down in the colon. Um, in which case I feel like if you're one of those individuals and you're not taking it, then yeah, you probably are feeling more contractions because your colon is one of those ones that's actually overactive and you probably are getting poop to the exit faster.
And most patients that we have on it have had a motility test either through SITS markers that you take a pill and we see how fast they go through. They may have a bit contrast enema that we're looking at as well. There's a lot of testing that we would do before we would consider putting somebody on Lomotil.
And there was another question, which is when doing the MACE, there is a lot of fluid that comes out. But how do you distinguish between that and diarrhea?
that's a good question. So, okay. How do I wanna guys, somebody step in.
Well, I think that's your goal you're going to see a lot of water because you're putting a lot of water in, right, Mary Ellen?
Yep, I think I mean, whatever you're putting in, you want to see out plus the stool that was in between. So you should be hopefully getting all of that out. So
Right.
depending on what you're putting in, you're going to see more out, right? If you're putting in 600 mLs versus 200 mLs. And I think it's okay if it's all coming out within a reasonable time after, like when you're sitting, that's okay. That's not really diarrhea. That's what you should see. It should be pretty loose stool that's exiting.
And it's murky. It's, when in the toilet, right? You don't always see, the harder stool might be sitting on the bottom of the toilet, but you don't see it because the water's murky.
Right.
So unless you're using a specific commode with a bucket or something where you're actually able to see what the stool is, it's really hard to tell what has come out other than what you're hearing come out.
And how much water should we drink?
It's
I love it.
usually half your body weight in ounces. is the recommended.
Mhm. Also,
Okay,
doesn't say blanketly at least 2 liters for an adult.
Yeah.
Yeah.
and is that daily? Then, yeah, that's
Yes,
daily.
sorry.
All right, and
And
then
we usually say try to drink that water about like do 16-ounce water an hour before you're going to calf. And then that way you're going to make a lot of urine in a short period of time. And then you calf and you stay dry for a lot of my patients.
Mm-hmm.
And then the last question that we have is, and thank you so much, everybody, for all of your questions, but we can't take any more tonight. So this is the last question. My son has a colostomy and his stool goes from way too firm to very loose, and it is not normal very often. We use a powder called Natural Calm daily to gently and more naturally keep things moving. We've tried adding in some fiber, but not having much success in making his stool more normal. What are your thoughts?
My thoughts are, I think you should speak, you need to see somebody about that. It's hard for me to make a recommendation if I don't know a patient. I know Calm is typically magnesium,
Yeah,
is
admittedly.
right, and magnesium often makes patients have looser stool. So it's completely, sometimes you got to just take everything away and start from scratch all over again, and just to add one small thing at a time. But I highly recommend under the guidance of your physician.
I'm going to second that because magnesium supplements like Calm as well can sometimes actually kind of interact if you have like a bacterial overgrowth of any type in your colon, like an abnormal bacterial growth. Magnesium can sometimes irritate that too. So I would recommend, just like Joy said, following up with somebody more specifically for that question.